Okay, so we've got the audio working. Okay, so we should be good to go. My name is Megan. I'm starting off ocular path rounds today. So let's get to it and make this big with a button. There it is. All right. Starting with this case, we have a 9-year-old neutered male pit bull terrier. They say, oh, an interesting history. Let's see. The patient developed Horner syndrome approximately 2 to 3 years ago, affecting the left eye, which is this eye. Evaluated by a neurologist at the time, who suspected. You okay? Yeah. Okay. Who suspected a trigeminal nerve sheath tumor, although an MRI was never done to confirm. Following that diagnosis, developed dry eye, managed with a bunch of medical stuff. Eye became red and irritated. A white film with small visible blood vessels formed over the surface. They added some more medications. And after starting treatment, the redness initially improved. However, the eye began to bulge and developed a bubble-like appearance, although the patient seems comfortable. That is the full history. So kind of interesting. A lot of kind of immunomodulatory therapies on the cornea and things like that at the time. And in terms of that bubble-like appearance, here's our hemisected view. We've got our little iris here who's kind of like squished. And here's the iris on the other side. And all of this is cornea. All of it. And all of this. So the bubble-like appearance was because of this really, really severe thickening of the cornea. On cut surface, the cornea is also pretty abnormal. It's opaque. Cornea should be clear. And it's kind of this reddish tan. And that's the main thing on the gross. So we'll take a look at histology. Oh, I don't remember the magic button. All right.
Not often do you get a history of trigeminal nerve sheath tumor?
Like never.
Yeah.
The weird history.
Just check.
And I don't know necessarily how this history is going to uh, mesh with our ultimate histology diagnosis. Yeah, me too. See if we can make a subgross happen. All right. For this large slide. It may be difficult. All right. So here is our globe again, kind of similar to our gross view. Again, we can see that little iris squished and our iris, and then we can trace all of this as cornea and tons of purple and red in our cornea. Very cellular. Let's look closer. Right. So now our eye has rotated 90 degrees clockwise. And we'll take a look at these cells. They're infiltrating the corneal stroma. They're pretty exquisitely confined to the stroma on this side, maybe a bit of limbal scleral invasion. On this side, they invade past the cornea into the limbosclera, into the episclera, into the bulbar conjunctiva. But mostly in the cornea. Let's start here, maybe. So in these areas where there's a lot of edema, lots of clear space, lots of blood, you can see that these cells are pretty round. And even as we go into areas where they're a little bit more densely clustered, wait for it, wait for it. I'm going to find an area that I like. Sorry. It's a roller coaster ride. Okay, hang on. There we go. Even an area where they're a little bit more densely cellular and not sort of in an area of edema, we have these sheets of cells, and they may not always be perfectly round as they kind of mold against one another, but they have these crisp cell borders. And what Dr. D would usually teach is if you can reach in with an imaginary pair of teeny tiny tweezers and pluck a single cell out without disturbing its neighbors, tends to be an indication of a round cell tumor. They are a relatively monotypic population, although there's quite a bit of nuclear pleomorphism, and they have a high nuclear to cytoplasmic ratio, so kind of a smallish amount of cytoplasm compared to the nucleus. So round cell tumor, and looking at this round cell tumor, my top differential would be lymphoma. So there's that. Part of the reason why I'm showing this to you, apart from kind of the unusual distribution and unusual history, is to show off something that I think is handy. If we go away from those areas of edema, maybe down here, for example, you can see that sometimes these neoplastic cells kind of form these rows. Maybe down here is even better. Hang on. So see how they're kind of forming rows regularly here. You can also see them forming rows in the other direction over here. Rows. There you go.
Single file.
Single file lines, yes. So oftentimes the arrangement of neoplastic cells is very important to decide what you're looking at. And a confounder in the corneal stroma is that the corneal stromal collagen fibers have a very specific arrangement. Cornea is designed essentially to pass light through. So the corneal stromal collagen arrangement is important for that. It's sort of this regular arrangement. And that can cause interesting patterns to form with not just neoplastic cells, but inflammatory cells infiltrating as well. Don't let that confound you. In this case, you could find areas where the cells were forming their round cell type sheets much more easily. But this case really demonstrates how, that kind of rowing effect can happen to some infiltrating cells in the corneal stroma. So that's one thing. And then the other thing is I'm not sure how the patient's previous history factors in. It's possible that maybe just this was a chronic pro-inflammatory environment in the cornea. We had dry eye, we had Horner's syndrome, potentially some neurogenic stuff going on. And maybe that chronic pro-inflammatory environment set up sort of a, tendency to develop neoplasia. That could be a thought. But otherwise, it's kind of unclear how it's linked, and still no news on, whether there was a trigeminal nerve sheath tumor or whatnot. But
Maybe that's the same tumor.
and that's the question too. Yeah, was it always lymphoma from the start that caused everything? Good point.
Immunophenotype.
This one, nope, they did not take us up on IHC yet.
Any history of topical treatment with immunosuppressives or anything like that?
Yes, I did kind of gloss over the medicines that were used, but they did use Optimmune, which I believe is a form of cyclosporin. Can somebody? Yeah, cyclosporin.
Yeah, there are potential correlations with immunosuppressive treatment and development of lymphomas or round cell tumors. Not very clear correlation, but there might be some biological explanation for something like that to happen.
Yeah, and certainly there is a published paper in dogs linking chronic immunosuppressive therapy, chronic corneal disease to development of squamous cell carcinoma too. So, yeah, it kind of might be kind of part of the same thing, part of the same deal. So
Impressive. The corneal-centric nature of this is very
Yes.
weird.
yeah,
Yeah. And add to epitheliotropic lymphoma, you can add corneotropic.
You're right.
corneotropic,
Keratotropic.
Yeah, correct.
keratotropic.
We like to mix stuff up.
Who doesn't? So yeah, here is our diagnosis. There aren't any other questions or comments. We'll do the next one.
Did you get any periocular tissue?
Good question. Yes, we did.
Did you try?
We trimmed at
Just
least
out of
one piece of eyelid and the third eyelid, and it was not in those.
Right.
Yes. The question was any other periocular tissue that we trimmed in. No trigeminal nerve biopsies or anything. So. Okay. The next case is a 12-year-old spayed female Shetland sheepdog. Let's see. They say large intraocular pink to red to purple mass arising from the ventrolateral iris and extending across 2/3 of the anterior chamber. A focal area of the mass was coming through the iris dorsolaterally at 10 o'clock. There was 2+ flare, fibrin, and blood across a discoric pupil. I like their description. It's very poetic. So here is our gross view. This is a second half from the hemisection of this globe. So you don't have the optic nerve head in section here. This is where it would be though. And it's demonstrating this mass. So the iris on this side is looking a little bit nicer, but on this side, this leaflet of iris is essentially elongate and sandwiched between this tan tissue here and here. And there's more of this tan tissue kind of glomming on along the ciliary body area maybe even more kind of multifocally along the uvea here. So an interesting distribution, and kind of more on the surface of the uvea, but also causing a mass effect. All right, let's go to the histology. Empty subgross. There we go. So we're flipped 180 degrees. All right, it's being weird. From what we just looked at on the gross, but here's that iris leaflet that's trapped between all of this purple tissue. Very densely cellular again. Let's take a look. Same thing here. And this tissue has this lovely appearance, histologically anyway, where we have necrosis. So all of this sort of pink stuff is necrotic debris. And then the survival of the neoplastic cells around blood vessels, which kind of leads to this serpiginous or, I don't know, gyriform look. Kind of pretty. You can use all sorts of fun words to describe that.
I was going to say good words.
Yeah. And these cells are pretty well demarcated, and you can often see them forming rows. And this isn't the cornea, so you can trust it. So here they are forming rows, kind of trabeculae, anastomosing, things like that. So this neoplasm is epithelial in origin. So this time we have an epithelial neoplasm. And the interesting thing about this is the way it is mostly along surfaces. It does also certainly invade the uveal stroma, but again, pointing out that entrapped iris leaflet, it's here kind of along the surface of, and then invading a little bit into the ciliary body. We can go to our extra section, because it's my favorite, despite the folds. You can see it invading here into the sclera. This is also Descemet's membrane, so it's dissecting a little bit between peripheral Descemet's and the deep corneal stroma, which seems to be almost kind of a potential space. Neoplastic tissue in this area tends to like to do that. So here it is in the sclera and in some scleral vessels. You have to be a little bit cautious about the vessels of scleral venous plexus with neoplastic cells in them, because keep in mind that this is a globe. The aqueous outflow will eventually end up in scleral venous plexus. So to some extent, you can get passive drainage. And neoplastic cells tend to like to kind of climb along the vessels outside them too in this area. So be cautious about overinterpretation, but this is kind of concerning because we do have these little tiny lobules of invasive neoplastic cells, then also this vascular invasion. So we've got carpeting of surfaces to some extent, and we've got maybe vascular invasion. These are things that make us concerned for metastatic neoplasia. And also this doesn't really have the appearance in terms of arrangement and cell morphology of a local epithelial tumor, meaning interstitial adenoma or adenocarcinoma. So we're worried about metastatic neoplasia. And then in particular, we have this neat feature in this tumor, neat for histology at least. Look what we have here. In these neoplastic cells, we have these bright pink cytoplasmic globules. They're very pretty. So this is most likely trichohyalin granules. And I'm going to switch and do a nice little bonus surprise for you here really quick. Keep in mind what we were just looking at. This is a piece of skin from the periocular tissue of a horse. Unrelated case.
Hopefully.
Nice little bonus. Nice little bonus.
An explanation.
Nice little bonus of solar elastosis in this case, really severe. This is one of the best solar elastosis cases I've seen in a while. All of these serpiginous basophilic strands in the superficial to mid-dermis coalescing here. This horse needs some sunblock stat. But the reason why I'm pulling this skin is to try and find you a hair follicle and show you what we're talking about with this trichohyalin, which I could have done a dot and that would have been faster, but no, I didn't. There's at least one hair follicle that shows off trichohyalin in here. Dang it.
Don't worry, take your time.
Yeah.
Thank you. Four more minutes off. There are some really cool cases coming up after this, so I don't want to take up all the time. I mean, also just in general, I don't want to take up all the time. Dang it, literally found one before this specifically for this purpose and then didn't mark it.
Primary tumor. There was really prominent morphologic change in the neoplastic cells around blood vessels where they became more columnar and they actually making palisades around it. That's not typical of a follicular tumor.
Interesting. I mean, it could be another type of protein, then trichohyalin.
With trichoblastomas, you can see that palisading.
Yeah, that's true. This would have to be a malignant
Try-
trichoblastoma with
That one.
metastasis.
Sure, I agree with that. That would be.
And wait, what?
Oh, we're just discounting all of our theories.
You know what? I can't find
If
it.
you can't find them, can you show them where it's like, show us where they would be?
Essentially, they should be in hair follicles. Wait, what? Where?
There's one.
Where?
Lower magnification.
Lower magnification?
Go to the upper left corner, right there. That's the individual of it's coming down from the circle. It's right there. Should have trichohyalin granules right there.
They're mostly keratohyalin there. I don't know.
Mm.
Oh man, this is killing me. I should have marked it.
I think it's time to move on.
Okay, it's
Yeah.
time to move on. Here we go. Should have marked it, or else the marking pen hand.
Beautiful solar elastosis.
Yeah, bonus. It was meant to be a bonus and then also to demonstrate trichohyalin, so we got one of those things down. So here we have our epithelial neoplasm again. And yes, so the thought is that this might be a metastatic follicular neoplasm of all things, malignant follicular neoplasm. Probably trichoblastoma would be the best bet, but it could be something else. Regardless, metastatic carcinoma would be the diagnosis for this. So we'll
Dr.
switch
D
to
said
this.
that he wondered about medulloblastomy just based on the
Interesting.
distribution
I like that.
of the cells. But I agree that there is a metastatic distribution pattern to it too.
Yeah, definitely this is a stage the patient kind of a moment.
Right.
Look for a primary tumor and look for additional sites that may or may not be affected. Interesting patterns in a metastatic carcinoma. And that's it. I've spent enough time already. I'm shifting. How did I do? Not bad.
You spent 2 minutes.
Hooray!
Thank you, Dr. Klein.
Oh my God. Okay. Next up is Kelsey Brown.
Thank you.
All right. This is Kelsey. I'll be going through the next 2 cases. I forgot to put a little blurb on this slide thanking the clinician for this photo. So thank you to the clinical team. So the first case is going to be the eye from a 1 year, 1 month old male castrated Yorkshire Terrier mix. In the history we received is that per the owner, there's acute onset of squinting. Sounds like it started 2 days prior to enucleation of this eye, which is the right eye. Clinically, they suspected endophthalmitis with fibrin and blood. The cornea was quite edematous, as we can see here, with deep vessels extending into the peripheral cornea. The globe was ophthalmic, there was glaucoma, and this eye was blind. The left eye, which we can't see in this image, was apparently normal. They also provided some additional history saying that there was no known or at least witnessed trauma. There is another dog in the house and they play together, and there are no cats in the home, which is important because we do see a lot of cat claw trauma. So it's good to get that history. All right. And grossly, when we looked at this hemisected eye, biggest thing we noted was that there was a copious amount of exudate or pus within the vitreous. And then we also have this gross image. So it sounds like our grossing team, when they looked at the other half after describing this eye, they noted within, so here, this is a what we call a gonio slice of the eye, where we have cornea,
Section.
or a banana section, yes. Depending on, where you're inclined to call it. So we have cornea, here's our iris, our iridocorneal angle, we have sclera, and this is going to be our vitreous here. We can see all that exudate, and we noted that there was this linear green foreign object that looks somewhat like plant material sitting in this vitreal exudate. So a little bit of a spoiler already for what we have to come, but it's a very pretty, very pretty slide. We will move on. to histology, starting with the hemi section. Let's see. So it's coming. We got it. All right.
It's unlocked now.
All right. Well, for future cases. All right. So starting with our subgross, we have our cornea up top, and our optic nerve is way back here. That's pretty big. And biggest thing is that there are just a ton of cells in all of our chambers. So anterior chamber, posterior chamber, and then the vitreous, corresponding to that exudate that we saw grossly. We can look at everything a little bit more closely. Only other thing at subgross to note is that it is a little bit busy too, just in the parapapillary and orbital tissue. But let's look closer. Okay. So this globe embedded kind of funny on the slide just because it was quite large. So our cornea is kind of at the bottom right corner, I guess. And there's not too much to say about the cornea. We can see that vascularization that was described clinically coming into the peripheral stroma here. Rest of the cornea is pretty unremarkable. Our iris, you can see here, here's one iris leaflet. It does have this kind of distinct shape where there's this anterior bowing of the leaflet, and then the margin of the iris kind of heads backwards. Oh, all good. Likely what was right here was our lens. So there's probably a posterior synechia, and this is an iris bombae. We can see our other iris leaflet doing the same shape. Likely just during processing or grossing, there was just some artifactual separation of the lens from the iris. We have some lens capsule over here too, so just things got a little bit chopped up during processing, which is common. As we go a little bit closer to look at our exudate in the anterior chamber, it's just a ton of intact and fragmented neutrophils. So in a lot of them, we can't really make out their nuclei. They kind of just become globbed together. A lot of these just look like essentially dead neutrophils. And there's this eosinophilic fibrillar material mixed within this exudate, and that's fibrin. So fibrinosuppurative exudate, a rather acute process. And looking at our iris, there is a bit of a uveitis, mostly neutrophilic. We see little neutrophils in the stroma. Maybe there are also some mononuclear cells in here as well. Primarily a neutrophilic inflammation. Going over to our lens, we have lost a bit of our lens capsule. It's been separated artifactually. However, I do believe that there is a lens capsule rupture here. We do have some cataractous degeneration of the cortical lens fibers, so Morgagnian globule formation, which is one of our hallmarks of cataract. And there are areas where we have inflammatory cells between the lens capsule and these cataractous lens fibers. Theoretically, inflammatory cells should not be able to traverse an intact lens capsule, so it kind of helps corroborate there probably was a lens capsule rupture here, even though a lot of the lens capsule is kind of perhaps artifactually detached. All right, then moving back into our vitreous, we have a very similar exudate. It's fibrinosuppurative. There's a lot of necrotic cellular debris in here, but more importantly, there are also tons and tons of bacteria. So we just have these clouds of bacteria. Okay, this is as high as I can go. In a lot of cases, they're kind of this more filamentous bacteria. And in some areas, let's see if I can find them. I feel like it's mostly these filamentous guys.
Wow.
There is a more, let's see, coccoid bacteria, maybe these guys. Yep, that's as close as I can get. Okay. Sometimes we do have these more like coccoid bacteria or let's see, or coccobacillus. Kind of hard to tell in these guys. They're so clumped together. But it does look like there is a mixed bacterial population. Yeah, these ones are probably a little better to look at, almost spaced out. We have a ton of mixed bacteria in here. And then moving back just to look at the rest of our eye, finish our tour. Here is our retina, which is truly detached. Here's our choroid back here. So there is this atrophy of the inner and outer photoreceptor segments. And there's also more exudate in the subretinal space, which corroborates that there is some degree of retinal detachment here. There's also a little bit of a retinitis, so some neutrophils infiltrating the retina. And then there's a similar inflammatory infiltrate in the choroid, just some neutrophils scattered in there. And then as we head back, here's where we do still have some orbital tissue. Indeed. There is inflammation, so we have more neutrophils out here, and then there's also pretty robust fibrosis. So we have these reactive fibroblasts, and they're interspersed with this kind of loose fibrous connective tissue. So there's some degree of orbital inflammation and fibrosis. All right, and then we'll move over to our banana slice. So again, cornea is at the bottom now. Very similar findings in this little banana slice. But additionally, within our vitreal exudate, yay, cute, we do have our plant foreign body. Here it is. And go even closer. And we have all of this hitchhiking bacteria on this plant foreign body. And this is what has brought in all of that mixed bacteria and caused this endophthalmitis that we saw. And as is requisite with any plant foreign body, we have to polarize it. So look at it.
Just go.
Oh my gosh,
Yeah.
amazing. In this case, it's a very obvious plant foreign body. This was not hard to find. In some cases, though, it can't help from low power to polarize. Cases where there's an endophthalmitis of unknown etiology, sometimes we do find small pieces of plant material, which is always a fun finding. All right. And that, go over to my diagnoses. So yeah, biggest thing is we do have a fibrinosuppurative endophthalmitis with mixed bacteria and then a plant foreign body. So this is a migrating plant foreign body. In a lot of these cases, we suspect maybe they migrate through the oral cavity, into the orbit, through the sclera, into the eye. And this particular dog is from California, which is a classic place that we like to see migrating plant awns specifically. But we can see them from all over the world. So geographic location doesn't necessarily dictate us seeing them.
And also, I think they specifically said in the history that they suspected the foxtail, right?
They said no foreign bodies found prior to nucleation. Owners live in California, so possible exposure to plant material, which I have redacted. But yeah, they knew what to look for. All right. If there's no questions, comments, concerns, I will move on to our next one. So this is the globe from a 13-year-old female spayed domestic short hair. And the history we received is that there was a large malacic corneal perforation in the left eye, which is the eye that we have here. There's no menace or dazzle reflex in this eye, and so they enucleated for comfort. And it sounds like the other eye had eosinophilic keratoconjunctivitis. So grossly, what we noted, this is a very odd hemisection. It's very distorted and hard to make out normal structures. But we technically should have cornea up top. But we don't really have much recognizable cornea. Maybe there's like these areas where there's this tan material that could resemble corneal stroma, but I will show you histologically what that is instead. This is where the limbus is, right here. And we have kind of this anterior protrusion of this pigmented tissue, which is our iris. So there's just this huge kind of protrusion that's mostly iris with this tan tissue on top. Our sclera, we do have recognizable sclera, is quite wrinkled. And then there's this kind of thickened orbital tissue that's pretty tightly adhered to the sclera. It sounds like we just left it on because we noted that it seemed abnormal and was very firmly adhered. And then here's our lens just kind of floating in the chamber here. We said it was subluxated. It's a little bit hard to tell its place with this hemisection because everything's just quite distorted. All right, so we will move. Are so gross. I can do this. Maybe. And turn it the other way. There we go. So
Confused eye.
it's confusing. technically, this is where cornea should be.
Artist formerly known as.
Artist formerly known as cornea. It is, cornea has left the building. And we have iris that has prolapsed through this discontinuity in the cornea. There's some tissue on the anterior surface of this prolapsed iris, which we can look at a little bit more closely. As we move back though. Again, here's our sclera. It is quite wrinkled and there's kind of this distortion of our structures within the eye, but these are, besides that, somewhat unremarkable. Really, most of the action is happening in the orbital tissue next to our sclera, where there is just more blue or purple. So there's some sort of cellular infiltrate within the orbital tissue. If I move this around over here, we maybe also catch a little glimpse of that happening on the other side. It's a rather extensive process. And right here, before I move to higher power, I can show this is where our limbus is. So technically our cornea should be here, and it's just not. So we can corroborate corneal perforation. Okay, so our globe has now flipped. The anterior segment is to the left, what should be cornea. And we're just going to go ahead and start with our infiltrate. So within our orbit and elsewhere too, we have this population of cells. Dr. Klimans has already gone through kind of the phenotype of our classic neoplasms. This one is not making rows. However, it is an epithelial neoplasm. Instead, it's more making these kind of lobules, sometimes trabeculae. And in some areas where we can actually make out their borders, they have a polygonal shape. Sometimes we can make out little like kind of intercellular spaces, but this is an epithelial neoplasm. And is exhibiting multiple features of malignancy. So we have pretty extreme anisocytosis, anisokaryosis. Some of these cells have multiple nucleoli. There's a ton of mitoses and they are bizarre. This does not look like any particular mitotic phase that I learned. And we have areas of what we call dyskeratosis. Go back a little bit, where in the center of these lobules, we have these cells that progress to develop abundant eosinophilic cytoplasm. Sometimes it gets a little glassy. And oftentimes these cells also develop a pycnotic or just lose their nucleus. So if you think about like an epidermis and the different phases as it becomes more superficial to develop the stratum corneum, you get this kind of phenotype. This is what we call dyskeratosis and an epithelial neoplasm. And in some places too, we'll also see keratin formation, so a so-called keratin pearl. And all of these are classic features of squamous cell carcinoma. And now we can kind of see where it's going. So it is within our orbital tissues. We'll kind of take a tour to the other side. It's very extensive. This is an extraocular muscle. You can see it just effacing the muscle. It's separating out the remaining sad atrophied muscles. There's a nice keratin pearl right there. Again, just hanging out extensively throughout the orbit. Unfortunately, also extended to multiple margins. And then somewhere, here we go. This is going to be our limbus here-ish. And we have Descemet's membrane. That's really all we have of it. And so at our corneal perforation, these neoplastic cells, they're kind of trying to be on the ocular surface or what we have left of it. And then they extend downwards into the anterior chamber. They are carpeting over our iridocorneal angle, over the anterior iris. So this is our iris that's prolapsing through that corneal defect. And I guess they're just trying to be corneal epithelium at this point. There's more of it. Sometimes what's on top of the iris is just granulation tissue. So all of this is classic granulation tissue with all these small caliber vessels and kind of this loose fibrous connective tissue. So granulation tissue is trying to do something here, probably in vain. And yeah, areas where maybe it's also infiltrating the iris stroma itself. And then we kind of come back to our other side where we pick up the peripheral Descemet's membrane again. Let's see. And there are also areas, it's kind of hard to tell if this is sclerovenous plexus, we're a little distorted, but there are neoplastic cells within convincing vessels. So there is vascular invasion as well. Then other things, there is also some inflammation in this prolapsed iris. And there's raging corneal disease, and there's also a neoplasm that is infiltrating the iris, so it makes sense that we would have a bit of an anterior uveitis. And then in some areas too, there's a little bit of an endophthalmitis too, or hypopyon. We have some neutrophils in here, which especially with a neoplasm, that's creating keratin. So we have areas like this in the anterior chamber. This is at the iridocorneal angle where we have these dyskeratotic cells sloughing off. We have keratin flakes. That's going to cause a acute inflammatory response. The eye does not like having keratin within it.
It's kind of funny to call that anterior chamber, right? Since it's
Yeah, I know.
it connects to the world outside, but it is theoretically
You know, as I'm saying it,
that
like
corner over
philosophically
there.
thinking, yeah.
Anterior chamber.
It's like philosophically, I guess I would call it that, but
Yeah.
it feels weird. I agree.
Not wrong.
Yeah, right. So technically a hypopyon there, but
Right.
it does feel weird. A marsupialized.
Right. Yes.
Okay. And then again, our retina is just kind of artifactually detached just because there is so much distortion of our outer fibrous tunics. Our sclera is just so wrinkled. We do have this suprachoroidal edema, which we often see with corneal perforations or scleral ruptures. Just there's this expulsive pressure when you have a discontinuity in the globe. And then also, lastly, the most important thing, there's a bit of a cataract. Very important to point out. So we do have some liquefaction of our cortical lens fibers. Probably not the most important thing here. All right. So this is a squamous cell carcinoma, as I mentioned, likely originating from the ocular surface. We have areas where perhaps it's communicating with our ocular surface, and definitely the cause of our corneal perforation and iris prolapse. In addition to that, we have intraocular extension and then very extensive orbital invasion as well. In some cases, with orbital invasion, because we have this effacement of our extraocular muscles, we can see restriction of eye and eyelid movement with these ones, which can mimic other neoplasms. So a really common one in cats that can cause that clinical manifestation is FROMS, so feline restrictive orbital myofibroblastic sarcoma. But histologically, they're very distinct. So in this case, yeah, very slam dunk squamous cell carcinoma, unfortunately. And with that,
Have they mentioned duration at all? I don't remember.
I don't
Maybe
remember
I forgot.
either. Nope, no duration.
Mm.
Mystery. So there you go. Yeah, squamous cell carcinoma, probably the ocular surface with vascular, intraocular, and orbital extension. So this one was going places. Right, and with that, I'm going to hand over things to Dr. Miller.
All right. Great. Hi, this is Jamie Miller, another pathologist here at Coplow, and I'm going to finish out with the last two cases for rounds. First up, we've got the right eye from a 1-year-old female spayed dwarf rabbit. That was diagnosed with a circular, well-delineated, dense white stromal abscess over the axial cornea, and what they call the pinpoint bullae-like spot centrally. They describe mid and deep stromal blood vessels extending actually towards the abscess all around the eye, and that the anterior chamber seemed very shallow, nearly collapsed nasoventrally. They weren't able to see much past that in the eye. They did do ocular ultrasound, and they said that the lens had increased volume with echogenicity and cataract change, anterior lens capsule rupture with extruded lens material into the anterior chamber. All this compared to the normal left eye. And then they also did an optical coherence tomography, or OCT, on the right cornea. And they said that the extruded lens material admixed with inflammation was in the anterior chamber and seemed to invade into the corneal stroma, which was interesting. So this is a hemisection of the formalin fixed globe. This is the other half of the globe because we do not have our optic nerve, which should be down here somewhere. But we can see with our cornea at the top, it is a little bit cloudy. We can see this white tan material here that's in the anterior chamber and kind of blends with our lens here. So you can see where they would have seen lens capsule rupture and an exudate here. And you might be able to, might be convincing here that it does seem to be in the cornea stroma as well, passing through here. Otherwise, the vitreous is a little bit cloudy. It's got some hairs on it. But other than that, we'll take a closer look at the section. Ooh. Oh, yeah. So, no, not what you should have with a normal rabbit eye. So cornea at the top with our, at least one iris leaflet over here that we could tell. Here's our lens, which is quite oddly shaped, and you kind of lose its borders here because all of these lens fibers have extruded out here, and it's joined by this hypercellular infiltrate that does extend into the cornea, as they saw with their advanced imaging. There's a little bit of that high protein fluid in the vitreous. This section here was a deeper section, so I did not capture the optic nerve head, which in the superficial sections just had some cautery artifact and was not really as striking as the corneal lesions. So we'll head up here. So you can see probably this might be what they were describing as maybe like the axial bulla that they were seeing clinically. Here is our corneal stroma. We've got desiccated membrane here. We've got lots of inflammatory cells here and no epithelium here at this point, so it is ulcerated here. If we take a little closer look at these inflammatory cells, we've got some nice heterophils in here, segmented nuclei, and really bright eosinophilic cytoplasm. Scooching a little bit closer, we can see this degenerate globular brightly eosinophilic material, which is consistent with degenerate lens fibers, which we'll see as we get a little bit closer into the lens. You could start to see multinucleated giant cells. We keep going. Here's sort of a nice area where we've got like some central heterophils and degenerate debris. We've got lots of lovely macrophages surrounding that stuff. They're very foamy with these big open nuclei, and they're surrounded by lymphocytes and plasma cells. So really pyogranulomatous inflammation going on here. That inflammation often surrounds all the lens fibers as we move into the lens now, or into the globe. We can see that our lens capsule is no longer continuous here. Let's see, here's one end of it here, where it is very curly. So if you weren't convinced by all the free lens fibers, here is lens capsule rupture. And again, just a lovely heterophilic and granulomatous response. We get lots of lovely multinucleated cells here. And some lymphocytes and plasma cells infiltrating the rest of the uvea and surrounding the inflammation as well. So in rabbits, especially these dwarf rabbits, this kind of presentation is pretty classic for a particular entity. Hopefully that is traversing through your minds right now. Here's some more evidence of cataract formation. We've got posterior migration of the lens epithelium and more degeneration of those lens fibers. So this is a pretty classic presentation for encephalitozoon infection in rabbits. They can be really hard to pick out histologically, at least for me. There is often a lot of nuclear debris around that makes it hard to identify. An extra special stain here. So this is a gram stain. Came with a blue dot to say, hey, look here, because they were a little hard to find, but I did find them. Get closer. More, yeah. So we have these gram-positive 1 to 2 micron organisms here. are really cute, which are really consistent, with the location here being in the degenerate lens fibers, in the lens, and their size and shape are pretty consistent with encephalitozoon infection here. So very nice example of that.
How do they get in the lens, Jamie?
So encephalitozoon is a microsporidian parasite that again is common in rabbits and especially dwarf rabbits, which is what this is. The exact pathogenesis is kind of unknown, but it can be transmitted vertically from the mom and enter the lens through the fetal vasculature. So during development stage, where they set up shop and they lead to cataract formation and then eventual lens capsule rupture, and then inciting this intense inflammatory response.
Very counterintuitive
Yeah.
way to get an infection, but
Yeah.
and just based on how often it occurs, I don't know why, but there seems to be a tropism for that pathway because it happens very often.
Yeah.
don't-
Usually the renal lesions.
Yeah, I could never find any explanation to why that tropism for the fetal ocular fetal vasculature.
Dwarf rabbits really do seem like they're overrepresented. There are different types of rabbits have different immunophenotypes for their capacity for immune response. And like these guys tend to have this disease. Pygmy rabbits tend to have mycobacteriosis.
Right.
And so there's probably some immune mediated process, something that's failing. So,
Yeah, just to repeat, if you guys didn't hear what Dr. Gasper just said, that there might be some correlation with some specific species to have a predisposition, an immune predisposition or idiosyncrasy to that will make them more susceptible to some specific infectious organisms. Good.
Excellent. Cool. All right. So, with that, our last case, you guys can play along with a guessing game here. So this is a 7-month-old intact female Maltese mixed dog. We got the right eye. She presented for refractory endophthalmitis in the right eye, as we can see here. She had a lot of tear staining around her eye. She had blepharospasm and marked conjunctival hyperemia and corneal edema. And they suspected hyphema fibrin adhered to the endothelium. They couldn't really see much past the cornea. They did note that she was very painful on retropulsion. And they did do an oral exam that was unremarkable, but did make the caveat that it was a limited oral exam because she was quite painful. They did do an ocular ultrasound, and they found something in the back of the eye that looked like it was penetrating through the sclera into the eye. So they recommended enucleation. So this is the hemisection of that eye. There was not an obvious defect in the sclera that I could tell externally, but we can see with our cornea up at the top, there is this white tract of tissue that does extend from the sclera towards what should be lens here. Maybe there's some leftover stuff here. And then we've got a lot of hyphema and fibrin and stuff in the anterior chamber as well. So very suspicious for a penetrating foreign body, as they had suspected.
I presume they anesthetized it for the nucleation, and did they report any other physical exam findings on the anesthetized dog?
They did. And that will come after I show you the histo.
There was a conspicuous absence of follow-up on that first stage of that.
It's called creating the suspense.
Yes. So I will also give a lovely shout out to our histology team. Because of that tract, it was kind of angled in the globe. And so we requested a superficial section and then stop on our case. Oftentimes for most of our cases, our histology team goes directly for our optic nerve head. But since we weren't really sure where that tract was going to end up, we did a superficial stop, and then I was able to take them the paraffin block with the tissue and say, hey, see this tract running through here? I want you to sample that. And left them to their own devices, and lo and behold, I came back with some lovely sections here. So again, here is the cornea at the top, lots of fibrin and stuff in the anterior chamber. Here's some fragments of what's left of the lens here. And then we can see the tract here. And they were awesome enough that they caught the defect in the sclera. We don't always catch that scleral defect when we have traumatic cases, but it's always wonderful when we do. So now the guessing game is, what do you think penetrated this dog's eye? So starting up front at the cornea, you did notice that there are a couple little breaks in Desma's here. So the object made it all the way to the front and seemed to disrupt Desma's membrane. Lots of fibrin, lots of hemorrhage in here. Here's our iris. We've got some little rafts of probably iridociliary cells floating around here. Here's our lens that is indeed ruptured. We've got some large swaths of lens fibers out here outside the lens capsule. And then we have some degenerate ones that are still inside what's left here. Here's some nice curling of our lens capsule, which is a good indication of true in vivo rupture versus something that happened after enucleation. And then we can follow the tract here. So we can see this space here. There's a lot of dark purple material associated with it. And then here is our defect in our sclera. So if we get a little bit closer here, you can see this very deeply basophilic material associated with this linear tract here. We also can pick up this like slightly yellow kind of refractile material in here as well. And if you've seen some of our other rounds cases, we have seen this material with a particular type of foreign body before. Am I keeping it mysterious enough?
Yes.
People guessing? We do have a little bit of necrosis here. We have a little bit of some retinal detachment. We have some macrophages coming in and some fibroplasia here. So it's starting to try to organize a little bit here. Here's a little bit of that fibroplasia here in the orbital tissue. And I did double check with the gram stain, and none of this, surprisingly, was bacteria, which was a little bit surprising. But presumably this deeply basophilic material is maybe just mixing with the fibrin. And so it looks a little bit maybe like bacteria, but it wasn't. So lots of debris. And so we have a foreign body in the eye. As a previous question was, they did intubate. And when they went to intubate, it's full screen here.
I was gonna say guitar string.
You're gonna say guitar string?
Yeah.
So yes, as they had mentioned earlier, they did do an oral exam, but it was fairly limited given how painful the dog was. So once it was anesthetized and started to intubate, they did note that there was a string entering the soft palate here. It did actually extend down the esophagus, but they were able to gently pull it out of the esophagus, and they kind of left it there. Let's see. Boom, boom, boom. So, and then during surgery, this was the foreign body it was still stuck in the eye when they took it out, and they pulled the string out through the orbit, apparently. So it was let's see, like a 4.5 centimeter long sewing needle with attached string. It's about so and it was free in the jar. So it was a little bit of a surprise when I opened the jar. Because I was like reading along, I was like, oh, decreased restful propulsion, oh, that's not good. And it was like, oh, what's this ropey material in here? Oh, there's a needle. So yeah, a little bit of surprise.
Well, we almost never get those, so it's
But
awesome.
it was
Yeah.
an awesome surprise.
John Golden here is raised his hand. This was my case. I was so sad when it fell out of the eye
Yeah.
right before I went to pull it in the jar.
Yes, yes. They they did note that when they were holding up the globe to take a picture after they had nucleated, the needle did fall out. So I did not include that in our pictures here, but
That's perfect.
yeah, it was beautiful. So
We collectively appreciate the effort.
Yeah.
yes. Much
I
appreciated.
mean, more often than not, we'll get the most ridiculous and strange, traumatic, penetrating, blunt, traumatic things with no history whatsoever. This time we even have like the murder weapon to change.
Yeah.
Yeah.
It's just perfect.
And just one more thing. They did note that on the ocular ultrasound, it was a linear hyperechoic structure that they could see
Nice.
penetrating on there. So
That's awesome.
Just discuss the significance of what you saw histologically and what this foreign body was.
yes, so it was a metallic needle foreign body, and so that deeply basophilic material is likely from the metal that is made up of that the needle is made up of. We see that a lot with like BB pellet foreign material in there, and that's where we've also seen that yellow refractile foreign stuff is with the BB pellets as well. So presumably that's something that's maybe coating the metal that's in there. We're not really quite sure what it is, but it's indicative of something metal, some sort of metal foreign body from our view. Could be rust, maybe. Could be rust.
Yeah, some
I
of the
don't know.
purple stuff definitely is probably iron.
Iron,
containing, so,
mhm.
yeah.
Yeah.
So ironic.
So ironic. Thank you, Dr.
Yeah, but there's the needle there too.
Yeah, yeah, you can see the little eye, the needle. This, yeah. So, all right. If that is it, I think we're ending right about on time. So thanks everybody for joining us, and we'll see you guys in 2 weeks.
Is everyone online?
Oh, sorry. I forgot to show my diagnosis. Needle in the eye. Get so excited to show the gross stuff, but there it is.
That's my word.
Yeah.
You suspect something in there. Who was the person?
John.
Yeah.
That's his name, right?
My cat chews on car strings. So like eat plastic bags and they'll chew on my
Just
guitar
start
strings.
recording
I like
and then-
change guitar strings and they're following you around. It's just like waiting. Crazy.